I just want to acknowledge that I'm standing on Wadawurrung country and acknowledge the traditional owners of the land. I also want to acknowledge that when it comes to endo health and pelvic pain, we know so little about the First Nations people, and it's so important that we include them, because without their data, we don't know what their experiences are like and what kind of care that they need. So my hope is that going forward, that we will be able to include everybody as we research and continue this journey of spreading awareness. Any questions throughout the presentation? We've got Edwina Coghlan here, who has very kindly offered her evening to talk to us about all things endo. But please send through any questions through the chat and I can ask them on behalf of you. Edwina, you were able to, I allowed you to screen share. Amazing.
Can you see now?
Yeah, it's not one slide though. We can see like.
Okay, no. I'll just put it on now. All good?
Looks great.
Okay. Thanks everyone for coming along. And hopefully you're all getting ready to wind down for Easter. Yeah, it's great to have, I guess, Kat advocating as always in the space in our region for endometriosis, and also Caitlin Pring, who's, I guess, leading the new the pelvic pain clinic, which was a great government initiative. But I would say that I think it's one of the best, it's the gold standard of how we should be managing, I think, pelvic pain. And so it's an amazing resource for our region. So, well done for everything you've been doing. And I guess we'll circle back a little bit to how we involve these great teams in our management for endo. But we've done a acknowledge to country, and again, just acknowledging, I guess, how difficult this is for all women and those assigned female at birth, but certainly the First Nations people, and already some of their struggles and the difficulties with kind of equitable access to healthcare. So I guess tonight's overview was really to think a little bit about endometriosis, and some of the common symptoms of how it presents. But also kind of go into the pelvic pain aspects of it and the chronic pelvic pain, which, we do know impacts on it, unfortunately, a larger portion of people that are diagnosed with endometriosis. And certainly, there's many people that don't have pelvic pain, so don't have endometriosis with persistent pelvic pain, but certainly we know that is one of the leading causes of the group of women and those assigned female at birth that suffer from pelvic pain. By the end of this talk, I think I want you to kind of think about, when you've got pelvic pain or you're caring for someone with pelvic pain, some of the symptoms that I guess commonly are linked to endo, and then also we want to think about some of the myths. I'm just going to tell a child who's baking a birthday cake for a sibling just to be a little bit quiet. Sorry. Can you just wait till I've done this? You can do the cake after. Sorry, it's a child's birthday tomorrow in the house, so they're baking a cake. And then I want you to, I guess, understand the importance of a good team for endometriosis. And it's really about thinking about a good team for anything. But, you literally cannot, I think, manage this condition or have a good response without a really good team around you, which we are very fortunate to have excellent practitioners in this region. So we're not going to spend too much time on this because I feel like you're all very much across it. But we know that endo is a bit of an enigma. It's not something that behaves the same in all patients. It presents very, very differently, but it probably conservatively impacts on at least 10% of women of reproductive age, and certainly 50% of people that fall pregnant. So who can't fall pregnant, it's probably up to as close as 1 in 2 people that have an issue with getting pregnant that have some endometriosis there.
Talk.
Sorry? Oh, thought that was someone trying to talk to me. And it's very much based around the menstrual cycle. It's chronic. It's got an inflammatory component, and it's like having a systemic, I guess, disease. And one of, I guess, the biggest ways it presents is with persistent pelvic pain. So you would all be well across it, the delay in diagnosis, but also more so for women and those patients coming from a rural or regional background. And that's, again, just our access to health care and good practitioners. So we know that that's for all, I guess, diseases, that there's a less access to good practitioners. But unfortunately, we've already got this subgroup of women that have a delay in their diagnosis, and then again another hit because they're from a rural and regional background. We know that it can be really difficult finding the right physician relationship, and if you haven't got the right physicians around you, it can be really hard to find physicians that actually are kind of, you're working really, that you feel are on your side, that you're all on the same page, that are advocating for you and giving you good care. There's certainly this kind of development, unfortunately, we get this central sensitization. So this aspect of chronic pelvic pain, that's really tricky for a group of women. And then we get, in some group of women, a disease progression and then adhesions and infertility. And again, this can happen differently for different women. So some people are getting, not able to get good care. Others are getting great care. Other patients don't have any issues with infertility. Others have got, no pain, but have got really tricky infertility issues. Others have their pain pretty well managed and don't feel that they have any of the kind of sequelae of the persistent pelvic pain. And I think that's what makes it so hard, is we need to really individualize the treatment and think about different practitioners and how they could all come together. Now, a laparoscopy, I'm going to come to that a little bit more, but there is definitely a poor correlation between how significant someone's symptoms are and the extent of their disease. And I guess what that means is that you can have patients that have terrible endo, and we do a laparoscopy, and so they have, we only find out about it when we do a laparoscopy, sometimes for another reason. And then we've got some patients that have really significant and debilitating symptoms that we're really managing and we're treating on merit, but their endo, we would say, isn't as severe, I guess, when you look at it macroscopically. But that doesn't mean that we don't kind of still treat these patients, I guess, the same, and make sure that we really individualize their care. So,
sorry, Edwina, I just wanted to jump in. We're using the word women a bit, and I just wanted to make sure we're being inclusive as possible. And I know that you were at the start, and I know that you are a really inclusive practitioner. So we also acknowledge that not everybody with endo identifies as a woman.
Yeah, it's one of those things, and thanks for bringing it up. It's one of those things that, you kind of do it and you do it for a little bit, and then I guess it's, I think, hard, to kind of continue the language all the way through, I guess, with some of our presentations. So thank you again for, I guess, bringing it up, but also knowing that there are, again, most of us that are in that space are pretty inclusive, are very inclusive, I would say. And also, I think also recognizing as well, while we quickly talk about, anyone that has pelvic pain as well, how triggering I think the menstrual cycle can then also be in that space of having potential pelvic pain and a diagnosis of endometriosis. So the next thing I just kind of wanted to just talk about was really us as practitioners, and I guess you as patients or clients or people that may be kind of having these symptoms, is you come with the symptoms. So you're the people that kind of have those symptoms, wake up with them, think what's going on. I've got potential constant pain in my pelvis. These are very medical words, but I guess I just wanted to let you know kind of, I guess, some of the approach from our side and the way that we're thinking. You've got constant pelvic pain. Dis is pain for Latin, so very, very painful periods, pain with sex, pain during a poo, pain during a wee, and then sometimes, getting pain that's starting to happen elsewhere. Sometimes, you might have, pain on like voiding. It could be pain that's then starting to happen without even getting your period, so just background kind of pain. And then when we kind of then ask further questions, we can kind of understand that actually periods have always been really painful, or, there's been issues with trying to conceive if wanted to. Sometimes siblings and parents are impacted. And I guess, it's important then to think about other things that could be causing pain at that point of view, but keep, endometriosis quite high, I guess, on the diagnosis or things that we're thinking about. And an examination, if we're thinking about endometriosis, and certainly, as part of the exclusion or inclusion of endometriosis for pain, but also when we're thinking about management, is so important, because I think about the pelvic floor, and I often say this to patients: if you sat on a pin in a chair, you'd jump off. So if your pelvis is in pain all the time, and you're always in pain, and you've had painful periods, your pelvic floor starts to switch on. And so we can see that when we examine. We can often, see some of the sensation across the vulva. Often I've been doing a very, a limited pelvic examination, but I think it's really important to make sure that that's done as part of the assessment of endometriosis or pelvic pain, but also know that that's a really important part of the management, because we know that 80% of those women, those that, don't identify as female, non-binary, anyone that's got pelvic pain, 80% of them will have a muscular component to the pelvic floor. And we need to help make sure that we're looking for that in an assessment and then really addressing that early on. And then people talk a lot about ultrasounds, and I think we should really think about having a good, high-quality ultrasound that's asking the questions and trying to, get a relationship. Sometimes your healthcare practitioner might say, look, go to this place for an ultrasound, and sometimes they're a bit more expensive or it takes a little bit longer to get in, but that's because they're people that are used to looking for endometriosis or and will do a good report. And certainly that's really important. And also you want to kind of have 1 or 2 scans, not having a scan all the time. Like, it's just not adding any information. So if you're going to have an ultrasound scan, I think it's really important that, when we ask for the referral, we have good information on there. But certainly, you're also getting a good report for what you're paying for. I wanted to just also show you, some of the older style way we think about endometriosis, which was, you took your history, you tried your anti-inflammatories and suppressed the menstrual cycle, you had an ultrasound scan, and then you skipped to a laparoscopy. And then it was either we confirmed endometriosis or we didn't confirm it. And certainly we've moved a lot more away from this. It doesn't mean that we don't kind of follow this algorithm to diagnose endometriosis, but we don't necessarily have to start the treatment for endometriosis after surgery. We can absolutely start some of those things and then think about when we should be doing a laparoscopy. When you think about some of the multimodal management, some of the anti-inflammatories, because it's such an inflammatory chronic disease, they're really important. Suppressing menstrual cycle, and we're going to come on to that. Our brains get better at pain. Just like if we went to the gym, we get stronger, we get better. Just like if we're reading, if we're reading, we get better at reading. If we're studying for something, we become experts. Unfortunately, our brain also becomes experts at things like pain. And so the more impulses it gets for pain, the kind of easier it responds to pain. It takes less stimulant. So sometimes we do give medications, and I often kind of discuss it with people about using it for a short amount of time to see if they get a response, or sometimes we're using it long-term, just trying to kind of help our other treatment and dampen down the central response of pain. And then a physiotherapist, if you see me, I think you get a referral to a physio and a care plan pretty much done concurrently. And again, we are blessed to have a group of amazing physiotherapists on the Surf Coast, in Geelong, down the Bellarine, who are just incredible practitioners who know exactly what they're doing, and we all work together with. I think, when you think about pain specialists and pain clinics, I think you should make sure that, I think at the moment, some of our gynaecologists do a lot of persistent pelvic pain and can start some of those treatments. And also the GPs, we can start some of the persistent pelvic pain medications. But I also think you don't have to necessarily see a pain specialist. Can you stop that, please? To do that part of the treatment. We're going to talk about why we use a psychologist, and then we're going to also talk a little bit about, I guess, would you go back for more surgery? When wouldn't you? And I guess the role of surgery. Very quickly, we know that chronic pelvic pain is when you've had pain every day for at least 3 to 6 months. We know that this starts to impact on all parts of a woman's life. It can be, when you're having pelvic pain, it can be coming from the uterus, tubes or ovaries, even coming from the bladder, the pelvic floor. And also there's going to be, when we say psychological component, that's because at the end of the day, you're in pain all the time. You're starting to get, it's going to start to wear you down psychologically. It's going to impact on sleep. People are starting to miss things, not exercise. it's impacting on relationships. So there is a mental, that's where the kind of psychological component comes into things. And we also know that the more anxious we are, if we're not sleeping well, then that does make our pain worse. If you're suffering from persistent pelvic pain and endo, you're unfortunately, again, like your brain gets really good at this, and you're more likely to then get back pain, headaches, and then have then impact on your mental health. Again, it's not simple and linear. We don't know, but we do know that involving a good team early on is able to kind of mitigate and modify some of these things. And just quickly, because pain is complex, but certainly kind of understanding it is important. So just quickly having a look at this, you don't have to really read the words, but really if you think about the brain at the top, and that yellow thing's the spinal cord, and the blue thing's the pelvis. So our brain does not know. You can't say, that's my bowel, that's my bladder, that was the muscles. It just goes pain. And so then what happens as all the organs are down in your pelvis, I guess you're getting your period, you've got some IBS symptoms, you've got a spasm pelvic floor. They also kind of get together and get really good at doing pain together. So your bowel starts to kick off your bladder starts to kick off your pelvic floor. And I look at it like, having like, a toxic person in the workforce and like the workplace, and then they can kind of like impact on the whole office environment, or when my kids are being naughty and they all start to kick each other off and I'm not sure who actually started the naughty behavior. So that's kind of what can happen over time and your brain's just getting this pain impulse, and we don't really know, who the main culprit is. So we need to make sure that we're treating them all. Okay. Should we I'll take a quick breath, and then Katja, do you want to add anything in before we think about some kind of common myths?
I had a couple of questions while you were talking, and I encourage anyone that's got any questions to stick them in the chat, or if you're feeling really, really brave, you can unmute yourself and ask them straight to Edwina. So you were talking about a good quality ultrasound. How does someone know where to get an ultrasound from?
I think it's reasonable. If you're seeing a gynecologist, most of them, sometimes we do a scan as part of our assessment, like listening to your heart with a stethoscope. But if you're going off to have an ultrasound scan and you've got quite persistent pelvic pain and it's really, this is not pain that's, you're at a point now, you're at a seminar listening to this, then I think asking to see a specialist, I guess someone that just scans women, and children. So like what we would say is it's a specialist ultrasound service. So your GPs should know who they are. And most of the GPs, if they think the patient's a bit more, more complex, like it's not straightforward, just I need an ultrasound to have a look at the size of the uterus, then they'll refer you to them. So you're looking for things like places that you go to have assessments for pregnancy care. And I think, I guess I'm not really answering the question very well, but I think as a patient is places that it's looking for a place that's got doctors, like gynecologists that are doing ultrasound scans as a specialty. So that's actually a whole, as a doctor, you can specialize in scanning. So they're a gynecologist and their subspecialty is ultrasound. The other thing, and as a GP, most of them, have their favorite imaging place they know does a good report.
Mm-hmm. I've got a question that's come in that says many patients have had scans and there's no endo shown, yet with a laparoscopy there is endo. So how effective exactly are scans?
So if it's deep infiltrating endometriosis, so that's talking about kissing ovaries, stuck pelvis in the bowel, then a good high quality scan should pick that up. And then they also need to look for it. They need to know what they're looking for, but 30% of endometriosis you cannot detect on an ultrasound scan.
Thank you. My next question I'm going to leave until after you've addressed these myths, I think. Yeah,
so I guess, sometimes we get told, my mum has really bad endo, she had heaps of issues with her periods and issues getting pregnant, and do I need to get diagnosed? And so my answer to that would be, well, it depends on your symptoms. So if you haven't got symptoms, and you're pretty well and you're living, you haven't got pelvic pain or you haven't got pelvic pain and you haven't got what we would say painful periods, then no, just because your mum had endo doesn't mean you necessarily will. However, if you started to get pain later on and, you know, if things started to change for you, it's important that we think about it. And certainly when you go to get pregnant, if you weren't pregnant within about 6 months, then you need to think about now, is this the way my endo is presenting? So yeah, sometimes someone has endo, they have a diagnosis of it and it's been well managed, and they have this kind of fear that it's kind of in there. They don't know what it's doing. And do they need to have like another laparoscopy just to kind of check in on it? And so we would say, no, the laparoscopy is not done kind of for like a check-in. It's done with a specific intention. So, you know, back in the day, and I don't know if you remember this, Kat, where people used to have the kind of annual laparoscopy, or laparoscopy was like really the main kind of stay of the treatment. And, you know, a lot of those people didn't get better because all they were doing was just operating, causing more scar tissue, putting gas in the tummy. And our evidence is pretty clear that recurrent surgery actually increases pain. It's just like if you keep, you know, rolling your ankle or doing, and so we cause a little bit of trauma when we do surgery. So that actually worsens pain. So no, you shouldn't just be having laparoscopies just to check in or as the only form of your treatment. However, if your symptoms were changing, or now you were trying to get pregnant, or, you know, things change, then we may consider it. But, you know, I guess the plan is to do a really good laparoscopy, treat the endo properly, and then then we kind of do multimodal management, and then we see how we go. And then think about, you know, potentially another laparoscopy you want to try to get pregnant. But it shouldn't be, you know, it's not there as kind of just a, how's it all going?
I've got a question come in that says, does scar tissue cause pain? And if you have had a lap does scar tissue cause pain if you've had a lap and all the endo has already been removed?
I feel like this question's a bit more, I guess it's more, if I've still got pain after my laparoscopy, is it because of the scar tissue? Maybe that's what the question is. So yes, a laparoscopy can cause scar tissue, but it's not, if you've still got resistant pain after having good endometriosis surgery and it all removed, that's pretty common. We know that the laparoscopy itself is not a magic bullet. And so that's why we need to think about, is your pelvic pain still really upregulated? You know, are you getting IBS type symptoms? Is this pain coming from the bladder? Do we need to kind of, are you just quite, you know, are you getting nervy type pain still because your whole central nervous system's so upregulated? So can we work on other ways to downregulate the pain? I would probably do that first before I called it scar tissue. It's very common. And I'm, you know, for someone to still have their pain to improve, but it still be there after surgery, because they need to think about we need to kind of treat the other things. It's not all women, but it's certainly, I'd say thinking that surgery just fixed it all is definitely a myth.
Thank you.
All right. So this is quite, so hormones are bad. So, and my doctors are really obsessed with hormones and they're trying to modulate my cycle. Can I just manage with other methods? So I'm kind of on your page here that it really sucks that we have to give hormones back to women and we don't have better treatment. And I'm hoping that, you know, when I'm older, that we've got much better treatment for endometriosis that is not just modulating with hormones. I guess the real issue is, even for people that, you know, wouldn't say that they're a woman, if you're born female and you have these female hormones, the problem is hormones is intrinsically there, what kind of, I guess, makes us have a menstrual cycle and makes us have a uterus and tubes and ovaries. And so the way for us to kind of, and the menstrual cycle is a huge trigger for many women with endometriosis or adenomyosis. So what we kind of want to do is, it's a bit like we want to try and suppress the menstrual cycle to kind of remove that as something that's a trigger for pain. Now, sometimes I wish I could do something else to suppress the menstrual cycle, but because it's hormonally driven, we have to try and then, you know, override it and, you know, give hormones back to try and settle it down. Now, we've definitely gotten better with how we do things. So we can do local hormones like the Mirena, and we can do sometimes progesterone only tablets. We can use better pills. We can change different ways that we deliver hormones to find the right one. But I think it's a little bit like, I don't know, going to one restaurant and deciding all restaurants are bad, but maybe you didn't go to the right restaurant or you didn't like the food there. So I think it's understanding why we do it. We're doing it actually to try and suppress the menstrual cycle, to try and stop you ovulating, to try and make sure that we can try and get rid of that as a huge trigger for pelvic pain, particularly for endo. And also, if we've gone in and spent hours taking out endometriosis and done really complex surgery and you've been in so much pain, we kind of want to stop it coming back. So if we've taken it all out and then you keep menstruating again for the next 10 years or next 5 years, then unfortunately, just like the endo got there in the first place, it often will recur. So I guess that's why we do it. And I think it's about keeping an open mind. I have lots of people that don't like hormones, and certainly I don't push them onto patients, and it's definitely your right to say, I'm not going to have that as part of my treatment. But it's a little bit like, I guess, totally saying no to all women's physios. And I'm like, we've just got to find the right one for you. So I guess keep an open mind, give it a go. And, also think about, okay, realize that we haven't, unfortunately, that's just the way our bodies work, and we haven't got better treatments for now. But I really hope that they're going to come with time.
We've got a question that says, doesn't endo still recur post-menopause, i.e. it's not just caused by the menstrual cycle?
I cannot confidently, I think, really answer that. I guess what it would more be is that, pain, like you're not cured by menopause, I think is more the thing. So because you've got often persistent pelvic pain and upregulation and pain doesn't just disappear with menopause or pregnancy because your periods have gone away. But can you grow deposits of endometrium outside in the pelvis? I mean, I'm about to go back, but not post-menopause. Once you've got the insult of the menstrual cycle gone, you may absolutely still get pain, but you're not going to be growing a huge big endometrioma or big endometrial deposits, because you just can't. Like your estrogen's gone because you'd be menstruating again. So you wouldn't be menopausal. But I'm interested to explore that a bit more, though. Is that based on people's I think what they're more saying is the symptoms don't go away with menopause. What do you think, Kat?
Yeah, I've just had Dr. Coghlan Pring adds that her understanding is that because you still have estrogen from fat cells and other sources post-menopause, you can still have some impact on endo.
Yeah, yes, but it's a bit like, yes. So I guess a bit like people that kind of have post-menopausal bleeding or a bit more overweight, absolutely, the estrogen's a bit higher. But I think it's not, it's certainly not, menopause is not going to fix endo. And you do have a bit of estrogen there, but it's certainly not that, I think, the same. It's definitely better than what, the impact of the estrogen is definitely less when you've gone through menopause. But thanks, Caitlin. That actually makes that's actually physiologically makes a lot of sense. Next one.
Yes, please.
Yeah, sleep and other stuff. So sometimes I feel like, and I think this is why having a good team and sometimes having lots of visits, and that's why these endometriosis consults take a bit of time, because if I just say, let's work on your sleep, you're like, why are you talking about my sleep now? So I describe this to patients is that when you're sleep deprived, or if I've been on call or did a week of nights, I used to get quite emotional and tired, and you're a bit more irrational, and I'd often be quite tearful and not coping as well. So if you think about the military as well, sleep deprivation is a form of torture. So when you're trying to torture a prisoner of someone badly, you sleep deprive them. And what do? They cave and they kind of start to tell you, it's a form of torture. So if you're sleep deprived, we know that we don't cope as well with everything, and pain gets worse. So, and then it's a chicken or the egg. Like if your pain's really bad, are you going to sleep well? So it's this kind of cyclical process. And so what we need to try and do is improve sleep to try and improve, how people are feeling well-being. And then often pain gets better but it's kind of, it's a tricky thing to do. And sometimes it takes a bit of time, but it's more that sleep, I think, is the center of all physical and emotional health. And it's very important. It's a skill, I think, that, and certainly when I see the adolescents who have got pelvic pain, you know, I'm like, if they're not good sleepers and they're on screens for a couple of hours, I have a pretty, you know, strong conversation with them about the importance of prioritizing sleep and learning to sleep well, because, you know, it's actually very important for their overall well-being. But certainly for people with pelvic pain, if you're not getting enough sleep, your pain, the brain's response to pain is definitely increased. And then if you're in pain all the time, you're not sleeping so well. So some of the things we do often that's where we do things like melatonin is very good. Things like low dose Endo are excellent for kind of helping with pain, but also helping with sleepiness. You know, that then often allows people to then want to get up and then getting up at the same time. So like not kind of sleeping in to like, you know, finally getting to sleep at 3 a.m. and then getting up at 9, 10 o'clock, you know, and then the cycle starts. So actually pushing through for those first few days, getting up at the same time, having a routine, and then the sleep starts to get better. But it is, you know, I guess we're doing it because we know that it's impacted on pain, but also it's central to the brain's response to pain. Anything else you wanted to add, Kat?
I was just interested, is there an optimal dose of melatonin, or does it depend on the person?
And where you get the melatonin from? So we use a lot of circadian, like just 2 milligrams, but it depends if you're having it compounded release, whether you're getting it on, people getting it online. So it's still very regulated in Australia. If you go over the States and Canada and Europe, you can just buy it over the counter. But the problem is you don't know what kind of dose that is. So not really. I guess it's more if it's working, I think. We know the doses of Endo, but not so much melatonin.
Thank you.
Okay, why the physio? So people also sometimes look at me and go, oh no, like I've had they kind of think, oh, my knee injury from netball or the back, you know, what's going on here? So I guess if you think about the pelvis, and I think there's a couple of physios I could recognize on the Zoom, their names, but so again, just like people decide that ultrasound's their special interest, as a gynecologist, there's some physios out there that think, wow, I could work just with women, and they go and do more training on the pelvic floor and the bowel and the bladder, and they're really well skilled, and that's their kind of area of interest. And they're amazing because they, I guess, understand the way the pelvic floor works. They understand that often your pelvic floor can be incredibly upregulated. If your pelvic floor switched on, you can start to get changes to your bowel and your bladder. You can have really painful sex. But I guess I sometimes see women who are like in so much pain, you can clinically feel that their pelvic floor is completely upregulated, and they feel like, you know, nothing's going to help me. And they have an amazing response to the physio, because the physio often shows them, just like going to the, you know, how hard is it to get, like if you had a knot in your neck, or you sometimes get like you know, your shoulders a bit sore, your back, it's really hard to get that out. Imagine if you had an upregulated pelvic floor to be able to kind of get it to relax without some assistance. So it's a muscle that's carrying you around all day. It's linked to your back. It helps you, it needs to kind of move with exercise. It needs to move with doing a wee. It needs to move with doing a poo. It's very important with sex. And so we need to kind of learn about it, learn how to move it properly, how to lift it when we need to, relax it. And then also if you've got trigger points in there from pain, then also how to kind of treat those. And so I think most, like I would say, and Caitlin can correct me if I'm wrong, but I think that really it's a kind of staple item with persistent pelvic pain and endo. I think at the point you've got just to kind of think at some point kind of touching base with a good women's physio. And I actually think that all women should probably see a good women's physio, you know, maybe twice during their life, when they're a bit younger and when they've had a baby, and then again when they're gone through their menopause, because they are very, very well educated, very good at their job, and it just adds so much to the care.
Yeah, I would agree. And it's certainly what is reported to us is that lots of people get great benefit from physio, pre-surgery, post-surgery, and as you said, at different phases of their lives.
I mean, I've had women that are in so much pain. And again, if you look at the data and the evidence out there, Verity, can you close that door quickly so I don't have to listen to them celebrating? Sorry, in the other room. If you look at the data for persistent pelvic pain and myofascial, like pain from the muscles, it's about 80% of people that have got persistent pelvic pain have an upregulated pelvic floor. So again, I think about it like if you ran a lot or you were doing heaps of exercise at the gym, you get sore legs, like you're doing squats, you get sore legs, but we can't kind of see it or feel it. And it's often that pain that's kind of persistent there all the time, low grade, kind of aches it's often when you've got that low grade pain there all the time, it's often coming from the pelvic floor. And it's so satisfying to see patients get a good response or just an improvement. Like it doesn't fix it, but it just is such an important tool. And I've had often I'll kind of, start some initial, if I think it's endometriosis, I'll kind of, talk about the options and we might start suppressing menstrual cycle, getting involved with maybe a pain psychologist and doing some physio and see how we go. Because their goal might be, I want to, be able to, and I don't think that they've got deep infiltrating endo and we're going to hold off on a laparoscopy or something for now. Sometimes that initial treatment and the physio, they're like 80% better.
Mm-hmm.
Right.
I have a question which is from your last slide, but it is, does amitriptyline cause tiredness?
Yes. So if I gave amitriptyline to Kat and another patient in this webinar who had persistent pelvic pain, one of them at least one of them, maybe both of them, but 1 in 2 women have a positive benefit to it. So their pain is decreased and they sleep better. Now, in medicine, sometimes we give 3,000 people aspirin to prevent one person getting preeclampsia. So that's an amazing thing. It's on the PBS. It's low cost. It's not, it's subsidized. But, again, it's around educating educating the person is that, I say to them, this is actually an old school antidepressant. We don't use it for depression anymore. In fact, if you had depression or I was going to treat your depression, I would use something much better. This is a medication that we're going to use at about, if we were treating depression back in the day, it would have been like 150. We're going to start it at 10 milligrams. Sometimes I go 5 to 10 because what it does is it helps the spinal cord response to pain. So where it works is this yellow bit here. So it helps modulate the noise and all the impulses to the brain and like dampens them down. And it helps with sleep. So if we can get sleep better and that background pain sorted, often people are much happier. It does make you sleepy sometimes. And that's what I say to them. It can make you a bit sleepy. So take it, normally I say like 8 o'clock. You don't want to drink too much alcohol in it. You can skip a dose here and there if you do go out, but I say give it 6 to 8 weeks. The literature has people on it at very high doses, but I feel like it's too high. There's too many side effects. So I feel like 10 to 25 is, sometimes a bit, if they're working, it's working well, then we do go up. But I find most people get a response at quite a low dose. And again, sometimes we do it around just to kind of help if the pain's really flared, and then over a bit of time when everything's better, we're like, do you want to try and stop it? So, and sometimes it does work a little bit on mood, but I don't think the dose we're giving at it for mood is good enough. And I would never use it for depression because at the doses I used to use, people are very, very tired, but we use it at a very low dose. Any more questions before I move to the next one?
Nope.
So the psychologist, you're thinking I'm crazy now, or is this in my head? Because why is there a psychologist involved? I think people get less, I don't know, because I think by now I've kind of spoken to them a lot about the whole process, so they're kind of on board. But I just want to put this out to you. So people see psychologists for all sorts of things, like high performance athletes, in the workplace, marriage counseling, try to be a better parent, stress and anxiety, mental health. Like a psychologist is not just for, because I think we've moved through the fact of psychologists, like a lot of people see them for very different things, and they're an amazing asset to the team if you get the right one, just like the right physio, right GP. If you've got the right people that we're working with, then all they are doing is allowing you to have tools and strategies to, deal with a complex disease, just like an athlete or an Olympian or a high performance person would use tools or strategy to deal with a complex workplace or being a high performance person. So yeah, it's just another person that's really trying to help the way our brain is responding to this stuff to get us into a better a mindset to, be able to take a bit more control over this. So, no, you're not crazy, but you've got a lot going on. And so, and we know that often the endo really has taken it out of someone. So just like you might get a psychologist or a counselor involved if someone was going through, their mum had died or they were having a big life event or marriage or even a positive life event, we're going to maybe involve them here because they've got some great strategies. And we're going to not just send you to anyone, but we're going to often involve with a psychologist that works in the women's health space, also works with us. And I actually should just touch on it very briefly. Unfortunately as well, about 30% of our community have some form of trauma. And so that trauma is not, sexual or intimate trauma. That's sometimes trauma that was bullying in the workplace, parents splitting up as you got your period, physical trauma, or unfortunately sexual or child sexual trauma. But trauma is big, and it really impacts on the way our brains respond to pain and that. So also the psychologist is really good sometimes at allowing us to kind of process some of the trauma if it's there so that it's not impacting on our pain. And I just had a thought, Kat, a bit like the women's physiotherapist or the psychologist or the ultrasound place. It's about not just sending to any psychologist or ultrasound place. You're sending to a physio that does this, an ultrasound place that does this.
Yeah, and as you touched on, the research shows that it's about the relationship with your psychologist, so it's about finding the right person for you. I'd also like to add, there's a great study of a guy that had what was a nail that went through his boot, and he was in excruciating pain. And they rushed him to ED. They didn't want to touch his foot because every time they went near it, he was screaming. And then when they x-rayed it, it had actually gone between his toes and it hadn't injured him at all. And there are other cases of people being bitten by sharks and having no pain. And so it's quite complex, but the brain is quite heavily involved in your experience of pain. And sometimes a psychologist can help with some education around that, but also getting an understanding of the role that your brain plays in this complex condition.
Yeah, absolutely. So I guess, this is one of my last slides before we open it up, but, I know that, again, we use the word patient a lot, which sometimes can be controversial, but that is kind of in medicine, I guess, how we do still use the word, or client. Again, I think it's about a really good team here. And so, if your GP is referring you off to a gynaecologist, that's really important. If you're, thinking about someone that's got an interest in pain, like I said, fortunately here, a lot of this does happen in-house. Good physiotherapist, psychologist. And also I wanted to touch on very much on complementary medicine, because we've, again, got some fantastic people that work in the complementary space, also osteos and and also some chiros that do some pain stuff, and a lot of people that are doing acupuncture. And I guess I'm just gonna, have I got one more there? I'll just stop sharing quickly. I guess my kind of feedback on that is we don't have a lot of the evidence there. We're not going to run a trial. In medicine, we often want to look at what's the evidence, but they are starting to do some trials on things like melatonin and, the role of acupuncture with persistent pelvic pain. But unfortunately, a lot of the industry is funded by, well, can we make money from this? Or, are we, like some of the drug trials and that stuff. And I just think that we're not going to have that evidence. So we can't tell you that this is better than that. But if it's not harmful and it's making you feel good and you can afford it, absolutely do it. Like, that's what I say to my patients. If you feel that the naturopath or the acupuncturist is a really valuable part of your care, and you think it's really adding to it, then absolutely keep doing it. but I can't tell you which one's better or worse because I don't have the answer for that. I mean, and I can tell you that I don't think that's helping you if it's harmful, but there's very few things I think that we think are really harmful. I think what we do think is harmful is lots of pain medications because they don't work over time, and lots of surgery.
And Dr. Caitlin Pring also said that a dietitian and a sex therapist are also integral members of that team.
Yeah, absolutely. I guess the dietitian, did you want to talk about the dietitian a bit? I mean, I can, but I just thought I've spoken quite a lot, but Kat and Caitlin about, yeah, I guess the role of the dietitian.
Caitlin, do you want to jump in on that one?
Yeah, look, again, an area where there's not a great evidence base, not because it doesn't help, but just because I think the studies haven't necessarily been done or been done well. But because we do see so many patients with coexisting bowel symptoms, you know, fluctuating constipation, diarrhea, bloating, food intolerances, there can be a real tendency to cut lots of things out when you have chronic pain, which is not a very nice way to live. And having a dietitian that's experienced in women's health and pain and hormones can be really helpful to try and figure out, you know, how do we add nutrition in and what things make you feel good, and help explore, you know, are there, you know, actual underlying gastro issues that we need to rule out. And yeah, the other one is a sex therapist, because it's another area that I think often gets missed by GPs and medical professionals. We often don't ask the question, but when you have pelvic pain or endo, and particularly when you've got that pelvic floor tension and spasming, penetrative sex can be really uncomfortable, and that can have a whole lot of flow-on effects to mental health and relationships and all those things. And so a good pelvic floor physio, again, will be able to give tools and tips and even toys or equipment to help with that. But sometimes a sex therapist can be really good for like couples counselling, or adding in some extra advice about how you might return to sex or have pleasure. It's not just about the absence of pain, it should be about pleasure as well.
Yeah, absolutely. I think the other thing I was going to say, my addition to the dietitian, is if it's not endo, or even if it is, you know, when I talked about before about the you know, the naughty friendship, like when they've got someone that's kicking off the friendship group, or my kid's being naughty, what happens is if you've got persistent pelvic pain or endo, then you often do get bowel symptoms or IBS type symptoms. So it's, I guess, starting to modify those, but also making sure that you're nourishing your body and you're eating really well. There's a couple of great apps that you can do from home called Nerva, which is really good with IBS. And also just understanding that maybe this pain isn't my endo now, it's actually bowel pain. And so they're really good with pain education, I find, the dietitians as well. I think with this, I guess the thing that as well, with the sexual therapists, I think they are really good. There's a couple down here now and they're quite hard to come by. I don't think in terms of if we can get on top of stuff and have a good relationship with a good gynae and a good GP, often some of that relationship stuff can be overcome. But I also don't think that, you know, all these different members, like everyone will see. So it's about prioritizing what's important for you. So if, you know, really the relationship's suffering and you feel like it's something that you don't feel like you can improve just with maybe seeing your psychologist and seeing the women's physio and the GP and trying to like talk about it, then yeah, we kind of bring that in. Or whether, you know what, my bowel, I've actually got really significant IBS with this, let's bring that person in as the next member. And sometimes that's more important for that person than, you know, seeing the women's physio. But I say to people when they come in, you know, this pain's been there for, you know, sometimes 6 years or 7 years. Unfortunately, we're not going to just make it go away this week by this one visit. We're going to have to step through a few different things. We're going to work out what's working really well or hasn't worked so well. And it may take, you know, a couple of different visits to get you optimized, is the word I say. I don't say cured or better. I'm like, we're going to get you optimized to really try and, you know, get you on top of this and kind of get you a bit more back in control of it.
Thank you, and thanks for that presentation. Does anybody have any questions? I've got one that's come through. It says, what about extrapelvic endo causing issues throughout the whole body, such as diaphragm, endo on the bowel, etc.?
It's pretty rare. Like, it's kind of, I think I've seen, was it more like, I guess, was the question how common that is, or what can happen with those?
It was just saying patients may not be aware that it can spread.
Yeah, it tends to be a bit, it can definitely spread into the bowel of the pelvis. But again, I guess it's more, does it matter? But yeah, what's the intention of wanting to know if it's on? Some people do have it badly around their bowel and don't have any symptoms. So it's more that if you're having the symptoms, knowing that I guess we want to stop it spreading there or remove it. But just because you have endo, that might be, over your, more advanced, doesn't necessarily mean that, it's going to be, you can have worse symptoms than someone else that's just got, we'd say more minor endo. And it's pretty, like some of those more rare ones, like up under the liver or diaphragm or in the belly button, are pretty rare. And sometimes, again, like I think, remember reading some of the case studies, they were just found, the person didn't even know they had it. So that's, I think, the frustrating thing is the symptom severity does not correlate often with how bad macroscopically we would say the disease is as a surgeon.
It's part of the complexity.
Yeah.
I've got a question here. If I don't know if I've pronounced this right, is Synarel, is that right? Synarel is working. What long-term options are there, and would a hysterectomy give the same benefits, or are there other options?
That's really tricky. It depends on if Synarel's working, then it's something that I don't use often, kind of first lifeline. Like I normally use other things like other suppression agents rather than going straight to Synarel. But if that was working, then I guess you might not need a hysterectomy. Or if you had a hysterectomy, the problem with Synarel is that it's going to, again, that's working centrally, it's hormonal. It's a type of, it's a gonadotrophin. So if you have the hysterectomy, you're still going to potentially need the Synarel to suppress any extra deposits that are growing or certainly any ovulation. And taking out, even if you're on Synarel and you're not ovulating, like we've suppressed you've still got baseline estrogen there. So we wouldn't want to go in and do a hysterectomy because that can impact that's your overall for health and other things has its own kind of, do take out your ovaries without a very good reason, because that in itself can cause other issues.
It might just be worth explaining, Edwina, that Synarel is a medication that just gynecologists can prescribe, and it essentially sort of switches off your ovaries and puts you into a menopausal.
Yeah, Synarel is just like giving back estrogen or progesterone. It's naturally produced from the body. It's called follicle stimulating hormone. So it's what the body produces from the pituitary gland to push down to the ovaries to start ovulation. And then as part of ovulation, actually, in fact, I'll just kind of share quickly because I love a picture. Sorry, I'm just going to move everyone's little faces. Oh gosh. So if you go to this, we didn't spend lots of time on this, but often I will show this picture to people when they're with me. Got one for polycystic ovaries as well. So this is this blue line here. This green line here is what we call follicular stimulating hormone. So what happens is on day 0 you get your period, so the menstrual lining sheds away, and then our brain starts to push down follicle stimulating hormone, which is called Synarel. So it's what we use for IVF to go recruit all the eggs, and then you get ovulation, which is this one here. And then in the second half of the cycle, progesterone's dominant. Now, the way progesterone works, estrogen causes lining of the womb to grow. Progesterone's only released by our body if we ovulate, and progesterone causes the lining of the womb to prime, I guess, for pregnancy or thin it right out. So if you give a Mirena to someone all the time, it kind of stops the endometrium growing back. Often it's kind of used to stop bleeding. So, I guess Cineral is against essentially like giving, it's a hormonal treatment, but it's not kind of, only some people kind of use it, and it's not very common. I feel like something else I was going to say, but yeah, I think it's sometimes important to realize, okay, it's so much is going on there. It's actually really quite hard to find the right hormone that can, you know, stop ovulation without causing side effects, that can thin out bleeding. It's hard.
And apart from a dietitian, is there anyone else who you should see for bowel issues?
Yeah, so I've got a couple of really good gastroenterologists that I've now linked in with, that actually have an interest in, again, it's like finding a gynecologist that sees pelvic pain and isn't just, you know, wants to actually manage IBS type symptoms. So it's two gastros that I work with quite a bit. One at Epworth, one called Chris Hare, that's really into kind of, does a lot of IBS and complex pain. And so I think if you can afford it, getting, you know, a gastroenterologist that understands functional gut issues is really good. And the physio is also awesome for optimizing your gut function, making sure you're pooing correctly, that you're, you know, if you've got any IBS type symptoms, because if your pelvic floor is really switched on, you often get changes to your bowel function.
Also not necessarily first line, but we know that gut hypnotherapy can be as successful as a FODMAP diet.
Yeah. Gut hypnotherapy, I'm just going to come back to the gut hypnotherapy quickly, because I just thought this is the question that everyone asks. And even I, as a doctor, when I was like in a registrar, I was like, this is a light bulb moment. People are like, hang on, if I've got all these hormones going on here, but you're giving me then, are you going to make me ovulating? So like I was thinking about the Cineral. So when we give the brain a constant dose of Cineral or the pill, all we do is just stop the brain being able to ovulate and do all these things. So it just kind of it kind of takes over from the menstrual cycle. That makes sense. So that's why we're not going to like make you ovulate more or do things. We're just going to like stop it, take over from the brain to allow you not to ovulate. So the hormones are still there, but you're not having these massive fluctuations. Gut hypnotherapy is incredible. It's got very good, high quality evidence. The Nerva app is really good. So a lot of again, it's pain education. It's understanding the bowel related pain. You know, sometimes and it's incredible. Like I refer a lot of people for it. But again, it's finding the right team, and unfortunately, it's just another thing. So it's quite expensive, but I've had patients that have had excellent results from it, and they can do it online. Mm-hmm. So Chris Hare is a really good gastroenterologist at Epworth.
Are there any more questions?
Well, I hope that was helpful.
I learned a lot, so thank you.
Nice.
And thank you very much for donating your time to us in the evening, particularly when you've got a birthday cake baking in the background. So I really appreciate it. And thank you for all the effort you've put into all of the information that you've shared with us all. I'm aware that on the recording, because of the way that the screen's looking right now, your name may come up. So I can see the question that's just been asked. I'll get to it. But if you don't want your name to come up on the recording, or you'd like me to wipe it out in some way, can you send an email to Catherine@endohelp.com.au? It's on our website, and just let me know, and I'll make sure that your name doesn't appear if for any reason you don't want it to. Someone just said thank you very much for answering all the questions, and we're getting lots of thank yous coming through. So thank you everyone for taking the time to be a part of this, and thanks Edwina for sharing all your wisdom with us, and thanks to Cardinia Pelvic Pain and Endometriosis Clinic for, you know, having the idea to get us all together to do this.
Yeah, and again, just thank you as well, because there's a couple of practitioners in here, but I feel, you know, while we are at disadvantage sometimes, well, I don't feel like we're at a disadvantage down in the G-Town and the Surf Coast, but I'm just very grateful for the just incredible group of practitioners and advocates like yourself in this region, because I do feel that, you know, you can find the right practitioner down here that matches with you and your goals. So it's a really good place to be in. And I think keep pushing on everyone, and, you know, keep the fight and keep doing what you do.
Yeah, thank you. And thanks to all those that are here that are also I know a lot of people are writing to MPs and writing to politicians, and the space is really changing because of that. So let's keep up the momentum and keep the conversation going.
Yeah. Medication for the PBS. That's the next one. And
yeah, that's right. Yes.
Menopause treatment on the PBS.
Yes, and changing that, there was
item number for consults. Yeah.
Yep, the longer consults as well. All right. Well, thank you, everyone.
Happy Easter.
Thanks.